Nice to meet you all. My name is Patrice Forget. I'm a clinical chair in anesthesia. I'm an anesthetist by training and a pain specialist also. I've spent 10 years in Brussels as a consultant there, and I worked, that's my 4th year, in Aberdeen. I plan to go or to be there for a while because I have an entire research program mostly focused on pain and opioid use after surgery. The aim of the research program is to improve not only quality of pain management, especially after surgery, but in general, but also safety of pain management. And I will focus mostly on that because I'm a clinician. I can easily speak about the different aspects of that, but don't hesitate to challenge me because you may have the embarrassing question that will be the most interesting one. In terms of a conflict of interest, mostly a scientific one, but for today, except the fact that it's an invited lecture or a seminar, I don't have any conflict of interest with GE. Let's speak about technology and the anesthetist work. That's relatively recent, rapidly evolving, as you know. We were focused on just clinical science before, and now that's a typical operating room, and there are many screens that are hidden, and that's always, we're overwhelmed by information, which is excellent, but sometimes important just to focus on what's really important. The importance of false alarm, dealing with that, the importance of integrating all this information is obviously something relatively complex, but we can deal with that without any big issue, I think. And that made in the last 2-3 decades, that made anesthesia management considered, and I will speak a little bit more about that, but that made anesthesia management considered as ultra safe in terms of degree of safety. If we speak about that with industrial language, it's much more difficult to consider that how to appraise that kind of technology after surgery in pain management in general when people are going back to the ward or even back on the road and back home. Short quiz, just to challenge you, because you're not necessarily aware of that kind of aspect. A few questions. What was the in-hospital mortality after surgery in users? I choose users because these are the most generalizable data that we have. Big series, 600,000 people, 10,000 in the UK. Little bit more than 10 years ago, but still, I think, interpretable today. Just think about that. How many people died after surgery during the hospital stay? Is it 0.5% or 5%? Not 50, fortunately, but just think about that, and the answers will come in the next slide. When you or me, I may be hospitalized, whatever the reason, what's the chance that I would get opioid, or the risk that I would get opioids? For whatever the reason is, I don't criticize that, just the fact, what's the proportion of patients, of inpatients receiving opioids in a hospital? What's the incidence of cardiac arrest in general? Yeah, difficult to know. In fact, even myself as an anesthetist, I have some difficulties to get the numbers, to know exactly what's the incidence of a cardiac arrest. Of course, we can track in a hospital mortality and things like that, but it's much more difficult to have a granular view on that, and especially on the cause. So what's attributable to opioids and what's potentially preventable? So 4% in users, that's an enormous number. 1 on 25 being operated won't survive the hospital. Sorry. That's enormous. That's the same number in the UK. That was 3.6 in the UK. So not fantastic at all. We may discuss about the design, the potential biases of the study, but basically these are the best data we have, and we definitely have something to do, even if it would be close to the lower boundary of the 95% confidence interval. It's definitely very significant. So that's in users. In the big observational studies that we have on cardiac arrest, specifically opioids, and this study looked at that by tracking, in fact, number of people getting naloxone also, which is a subgroup of people over-sedated, potentially over-sedated due to opioids, might be over-sedated for other reasons. But in this case, all hospitalized patients, that's a very big series from North America. It might be different in Europe, but basically we don't know. So it can be said that it's necessarily very different, but more than 50% of people, of inpatients, receive opioids during their stay. And 0.5% of people get unpredicted cardiac arrest in this series with more than 50% of mortality. So cardiac arrest defined as the first symptom. So not linked to, for instance, a long stay in ICU or something like that. And one of the biggest risk factor was receiving other sedative, but many patients also get sleep inducers, benzodiazepines, or the kind of medications making them at risk of respiratory arrest or cardiac arrest due to hypoxia linked to over sedation. So in this other series, and John Garrett and a colleague, but that's also from North America, looked specifically at patients receiving naloxone because that was more easy to track. And 0.1 to 0.2% of the people received naloxone with high mortality rates. And again, they looked at risk factors, and and just before speaking about risk factors, just to look at this chart, I mentioned the ultra-safe environment that we have in the operating room, and considering that the risk of mortality in theater is very, very low, about 1 on 10,000. So fortunately, that's not a place where we consider that intraoperative deaths are still frequent. But even with that, it's relatively infrequent that we compare safety processes in theater to the aviation industry when explaining that kind of risk to patients, because patients are maybe very afraid and not reassured very much to say that actually theater might be as safe as taking a flight. But basically nuclear industry, that's also the same, but nuclear industry, commercial aviation, and being anesthetized when you're fit and healthy is or can be considered as ultra safe. But then afterwards we send back patients to wards, and then we know that it's more in percent, unfortunately, that mortality rate can be estimated. So then we more around road safety, and unfortunately fatal iatrogenic adverse events are in this area, so much more looking like risk that people take when exposed to cardiac surgery. So that's much less safe environment. And even with that, I don't speak about going back home without the safety and the monitoring that people may get in theater or in ITU. So we need to do something, and if we want to save life, there is probably a place that we should invest more. That's postoperative wards, and maybe thinking about postoperative monitoring in general, and even maybe with wearable technology out of hospital. But at least investing more the wards with that kind of technology, that's something that I will look at, and it looks like it's frozen again, but apologize for that. But so just to present, thank you, a few numbers again about mortality, but it's just to show that we need to understand things better and do more research projects to understand what are the determinants of postoperative mortality. But these are just the last 100,000 people operated in Grampian, in the Aberdeen area, and in the last 100,000 people operated during the, it was nearly 10 years. One of the most important risk factors for mortality was a deprivation index. So that's a simple way just to exemplify the fact that there are many things and risk factors that we don't really understand. Probably covering different aspects like comorbidities, of course, but that's adjusted also for age, specialty. So just to be sure that, for instance, vascular surgery is not overrepresented because people may smoke more or things like that. So even adjusted on that, deprivation may represent or may cover other risk factors that at the mechanistic level may be important for patients, maybe like drug use or things like that, but basically we don't really know. So there is much to do to understand better, possibly to explain if we can, and possibly to modify or improve. So should we monitor these people better when or after discharge? That's still a question mark, but definitely the potential and the need is there, because these people die more than other people.
I've done for you.
Yeah, thank you. Apologize for that. If we speak specifically about drugs, of course, it's all about it's about all drug-related death in Scotland. But you know that even after 2020, so during the pandemic, the number of opioid-related deaths in Scotland, but worldwide also, has never been as high as there are now, and that exploded last 10 years. To what extent are our prescription opioids responsible from that? Basically, we don't know. We know from North America that it's definitely an important risk factor, being exposed to major surgery, being young, prescribe high dose of opioids, so we definitely need to decrease the amount of prescribed opioids, but we need to protect access to optimal pain management as well. So we need to improve quality of pain management, but also by improving safety of that kind of management. How to do that, and apologize,
We can do that from you.
Yeah,
Just
okay.
let us know when you want to share.
Yeah, super. We can improve safety by just delivering naloxone kits. That's an easy way. Scotland implemented, and the number of naloxone kits has been massively. So the number of delivered naloxone kit has been massively improved last 2 years. So that's in some way a success. And you have heard on the BBC just the adverts, just to explain to people if one of your loved ones might be intoxicated by opioids, think naloxone, and things like that. That's good, but that's definitely not enough. The number of deaths definitely continue to increase. And interesting, from this sub-analysis that we have done from the Scottish naloxone program, there is a concentration within the 12 weeks after hospital discharge, a concentration of opioid-related death. Some of these people may, of course, inject heroin or fentanyl, not prescribed for pain, but maybe some of these patients were just discharged on opioids, and there is an important reason and an overlap when we know that people suffering from opioid use disorders, in the majority of the case, suffer also from chronic pain, even if it's difficult to explain what's their story. But in general, there is definitely a problem after hospital discharge linked to opioid-related death. Next one, please. So what to do, and the next one again. So I've mentioned we need to improve the prescriptions as clinicians, and you can go again to the next one. And there are guidelines relatively well described for clinicians, and if you speak with your physicians, anesthetists, or surgeons, or even GPs, it's well known. We have old ways to describe that with the WHO pain ladder with just paracetamol, ibuprofen, simple things. It's not that simple, because then when you speak about that with your physicians, all they will say that they promote early recovery, drinking, eating, mobilizing. All they will say that they apply the principle of multimodal analgesia, opioid sparing techniques, procedure-specific techniques, and individualized pain management, shared decision process, and so on. But all they have different definitions of that, which is partly valid because local constraints or historical aspects or leadership may lead them to promote some aspects versus others. But that means that it's very complex because you have a variety of approaches that is very difficult to analyze and to consider. But we definitely need a better data, but we need also having the clinicians working together to know exactly what's the vision, what is the priority. Definitely quality is a priority, but safety also is. Next one, please. Closed loop system, that's not new, and you know that better than me, in fact, but we have old publications about pumps with noradrenaline, vasopressors to regulate blood pressure, and then closed loop and systems that may be implemented, but it's probably not something that will eliminate the need for doctors, fortunately or unfortunately. But that's anyway, closed loop, including humans, is definitely something that we consider in our daily practice and daily life. Thank you. And that's important. We discussed earlier glycemic control in diabetes. You may remember the nice sugar trial. I was just a young consultant, excited by the idea that very strict glucose control in the blood of people was saving lives, and the nice sugar trial tested that hypothesis, because that was very logical, that considering that allowing sugar to not to be strictly controlled was toxic for the organism, and if people exposed to infection or surgery, or the outcome might be worse. And in fact, the intermittent control with more intensive insulin therapy killed people. So the continuous monitoring, of course, that's just one example, but the absence of continuous monitoring might be dangerous if we consider dangerous medication like insulin. And that directly modified many guidelines for more permissive approach regarding sugar control, which may be reversed if we consider continuous monitoring. But just to say that when we correctly measure the importance or the potential limitations linked to intermittent monitoring, we can sometimes find big surprise, because of course that wasn't the hypothesis at all. The hypothesis of the trial was saving life with more insulin and strict glucose control, and that was the opposite. And the difference is not trivial. That's something around 2 to 5% of increased mortality. So that's a big difference. Next one, please. So what does NICE says in terms of priorities for perioperative care in adults. They speak about health-related quality of life, pain reduction, amount of additional medication, so trying to improve all these aspects, and adverse event. And if we go to the next one, you know this relatively old model, typical with the patient going to the GP possibly, depending on the type of system, but certainly to the GP first, and then we can go to the next one. Yes, to the GP first in the more modern environment, and when we speak about enhanced recovery after surgery pathways, that's typically what's done now. It's not anymore kind of disintegrated pathway when people go to surgery, but then everybody's around that kind of pathway to be sure that everything is done at the right time and for the right reason. That's relatively idealized model that works relatively well if we consider the shortening of length of stay during the last decades, which was definitely dramatically reduced. But we can, of course, improve massively the efficiency, because this long chain makes that very complex sometimes, and we know in our daily life that's the time we lose while doing nothing or doing not interesting things is definitely important. So that increased the complexity, but we may work now on efficiency. Yes, please. And there is still a big pressure, and even in the Wall Street Journal, a pressure to shorten length of stay, which was partly done for good reasons. Shortened length of stay were also done because safety was improved. So that's not bad at all. But next slide. And that's also because the technology made different aspects much safer while being in the hospital. This slide is just about the success story of neuromuscular monitoring. So when being paralyzed during surgery, people are asleep, and then they can be monitored to what extent the muscle strength is going back to normal at the end of surgery, and then being able to be awake with all their capacities for breathing well, for coughing well, for swallowing well, and to recover as quickly as possible. And then you see that from the time that where we didn't, as anesthetists, monitored the potential residual paralysis, and with a very impressive high proportion of persistent paralysis in people at the end of surgery, then it was possible to reduce that very, very importantly. So that can be done in theater during surgery, but then now we have to improve things also for postoperative outcomes. Yeah, thank you. And also some success stories. If we speak about postoperative morbidity and mortality potentially linked to people with low cardiac output during surgery, let's imagine a patient bleeding or having chronic cardiac failure because old or not fit enough for surgery, but needing actually the surgery to be done. Definitely monitoring cardiac output can be linked to an improved outcome and a reduced risk of mortality and morbidity. But that also depends on the context. And on the lower part of this forest plot, then you can see people specifically included in enhanced recovery after surgery pathways, and improving the pathway and improving the teamwork and communication between people, and to be sure that everybody does what they should, can improve the capacity of the control group actually to do as well as the intervention group. So sometimes we can also de-escalate more rapidly or de-implement some technologies because we understand better what happened, and especially when it's possible to de-implement invasive technologies and to go back to non-invasive one. That's definitely something that we can do to constantly improve also efficiency. Yeah, next one, please. So I mentioned that more than 50% of people get opioids when being hospitalized. That's an enormous number of people. Let's imagine on a yearly basis in Grampian, or just at Aberdeen Royal Infirmary, it might be around 100,000 admissions. So if we think that maybe 0.1, 0.2% of these people may have a preventable cardiac arrest due to opioids, that might be definitely a big win for these people. But I didn't mention the fact that many people have near-miss event or missed event when deteriorating before getting the a cardiac arrest, and then a few studies looked specifically at the proportion of people being hospitalized having just opioid-induced ventilatory impairment or just respiratory depression in general, and came back with dramatic numbers, like something like 20, 30, sometimes 40% of the people being hospitalized having respiratory depression events. Some of us at home may have also desaturation or respiratory depression. Let's just speak about apnea, hypopnea syndrome. That's something that many people may have and not knowing that they may have that. But definitely having something like 30% of the people being hospitalized and having respiratory depression events and possibly induced by opioids is something that we should consider, because these people then may progress to more profound hypoxia and be the person that we would like to target for the for preventing that. But you may go back to the previous one, just to mention that there are risk factors that we know. Getting parenteral opioids, also a dose-dependent effect, of course, bigger dose, more risk. Co-sedative might be one of the biggest risk factors, because all the other one, including parenteral opioids and including the dose, age, BMI, respiratory condition, ethnicity, and a major surgery are all important risk factors when we try to explain what happens. So to identify risk factors, it's much less performant when we try to predict actually who are the people that we should specifically target. And there is a risk if we target just the high-risk people that we will miss the majority of events, because diluted in a big population. Of course, that's difficult, because between monitoring everybody or nobody like now, we should probably think about targeting the right population, but we will need anyway to be wide enough when considering that kind of population, not to concentrate the effort on a very small population and then missing at the end the majority of events. But that's not an easy discussion. That implies mobilization of resources, that implies local aspects, that implies processes and pathways. But yeah, so we know some risk factors, but to what extent is that predictive? No, it's not predictive. These are just risk factors. Yeah, thank you. So going back to NICE guidelines and merging that with the Faculty of Pain Medicine guidelines, we can definitely implement opioid-sparing strategies, and I do hope, and I'm pretty sure that all the hospitals in the UK have already done that, even if a different way, implementing training, mostly dependent on leadership, and you know that well, part of our job is based on evidence, and fortunately that an important part of our job is based on evidence. But it's also massively dependent on leadership, historical aspects, and what people really would like to develop locally. So these leaders also need to be informed and just to be consulted and to be sure that we can respond to the need, but also that the needs are well identified. The difficulty with the 0.1, 0.2% is that that can be easily missed by the personal experience of people, because going to improving the safety makes the people losing that kind of a personal experience and then personal motivation to implement things that can be very relevant if we consider the 100,000 admission in a hospital. Specifically for the clinicians, being pain-specific, goal-oriented, patient-centered and monitored management are all part of the definition of what we call rational prescribing, so prescribing the right treatment at the right time to the right patient. We need to get feedback from patient in terms of quality of pain management, but also safety. Next one, please. And I may challenge you, maybe just for getting your feedback and your experience. That's a simple table acronym proposed by Frédéric Michard that might be interpreted in different ways. Frédéric Michard is a key opinion leader in postoperative monitoring. He's speaking much in congresses and things like that. And he just came back with this monitor algorithm. And that makes sense to me, but that can be understood different ways. The M is for many high-risk surgical patients develop postoperative complications that may be detected with a delay. Of course, yeah, that's right. That's why we have implemented in all hospitals the news charts, the manually or mostly manually, at least in Aberdeen, chart with the nurse going back to the patient and reporting vital parameters. Yeah, probably better than it was before without that kind of standardized monitoring. Some patients may need closer monitoring, like people getting a morphine pump, then they should benefit from a hourly monitoring. You can imagine the burden for the nurse in the ward, seeing a patient going back at the beginning of the night with a PCA and this terrible sheet of hourly monitoring during all the night, and she's alone for the 25 patients. So that's not that easy. Should we improve that with continuous monitoring? I mentioned that, the intermittent monitoring doesn't work always, so that's definitely something that we may consider, but difficult to prove, of course, difficult to come back with some evidence, because a randomized trial won't work well for proving that we can improve the incidence of cardiac arrest, preventable cardiac arrest potentially linked to opioid-induced ventilatory impairment, which might be something like 0.1, 0.2%. So that's not that easy at all. Then should we decrease the 30% of respiratory depression event rate? Might be, but of course we know that it might be dependent on patient condition at the beginning. But definitely improving monitoring may help, and I've proposed some examples of that. And that's because the O is opioid-induced respiratory depression should not harm any patient. That's preventable. That's preventable. There is no reason that we wouldn't be able to prevent it, but it's not that simple. It's not that simple at all. And we're confronted to a growing number of chronic opioid users, and if it's not for chronic pain, even if we know that about 5% of the population use high dose of opioids for chronic pain management, and these people are not necessarily tolerant to the respiratory depression effect with opioids. They may even be at higher risk because the postoperative pain management might be more difficult, so they will get higher doses of opioids. But opioid-naive patients also in some surveys are at high risk of opioid-induced respiratory depression. That might be dependent on local habits and especially adjustment of the dose of opioids prescribed or no adjustment, and then meaning that the opioid-naive patient might be more sensitive than the chronic opioid users, but it's not very clear. Anyway, and even not speaking about this, the people with substance use disorder, which definitely are a big problem also, especially in Scotland, but in the north of England also. And I strongly believe that Europe in general is definitely not protected against that kind of issue. That's not just a North American problem, and many countries face increased number of opioid-related deaths. Nurse to patient ratio is often suboptimal on hospital wards, and let's not dream that won't massively increase. That may be adjusted, and hopefully that we will find the 9.2% of staff member that we need in the NHS, but I don't expect that will be doubled in the next few years. It may even decrease more. That's a risk. Hospital cardiac arrest often and typically happen in wards rather than in ITU. And we have more fragile patients, overwhelmed ITU, and we have a potential solution with wireless monitoring. Of course, we may say that Frédéric Michard has some potential conflict of interest because he works as a consultant also for companies, but the general discussion, I think, is well supported by documented examples and anyway clinical need. Yeah, thank you. The next one, please. So in terms of gathering data, and I will go fast on that, but that's my research program, and I'm coordinating the PANDAS research group. PANDAS stands for Pain and Opioid After Surgery, and we try to document in the NHS Scotland and England, but also in Europe, what happens with opioids after surgery, and that will help us to improve not only quality but also safety of pain management if we can have better data about potential adverse event. And the next one. That's my last slide, a rich one or complex. Don't hesitate to react, but that's partly conclusion slide and perspective slides. And we could dream about, if we speak specifically about pain, and of course, yeah, you have well understood that's my field of interest, but thinking about a pain specific, I mean covering also individualized pain management, so improvement of quality of pain management. That's on what the PANDAS research group works, conducting different studies, but also maybe considering in PANDAS 2 what may be a guideline implementation trial, and that will be very complex if we consider that we can improve not only quality but also safety of pain management. That will need to build multidisciplinary teams to understand very well what's done and to understand what's possible, and not to add burden on the shoulder of the nurse in the ward and just to come with the nicest technology, but that will be just not manageable in the middle of the night because having something else to do, and that will just be in the cupboard and not used at all. So that will be a very complex process, and we will need to build partnerships with many different kind of people, possibly with the industry, but basically with people in the hospitals also, like you, knowing what works and what doesn't. We'll need to think about collaborating with primary care and addiction medicine. That's specifically for opioids, but definitely people after discharge, and I've shown some numbers. People die after discharge also, and after discharge might be even less safe than the wards when people are acutely ill, but when they are fit for discharge, they're not necessarily protected against the risk of postoperative mortality or post-discharge mortality in general. Shared decision process is an important aspect in pharmacological management, goal-oriented. I came before with the question about preparation lists as an alternative to waiting lists, so trying to get patient perspectives and to try to see not only on the medical point of view but also on a personal point of view which patient might be happy to have an adjusted pathway to improve their capacity to recover quickly and better, and that might be true specifically for opioid prescribing because people's perspective may be more for pain intensity control rather than for rapidity of recovery, and that should be recognized. We have now a very nice model to treat population, but not really to adapt the treatment to individuals' preferences, and that's very important because that's an important part of PREMS. We mentioned patient-reported experience measures. The experience is also importantly linked to the control that people have on their care, and we would like to express our preferences as potential patient and to say that's not something that makes sense to me because what matters to me is something else, and then at a different time of the life, then our preferences might be influenced at all. And we can do much as clinicians, and I mentioned here just the opioid-free approaches. We have no issues with identifying new medical strategies and pharmacological combinations and complex things, but we need now to expand the scope and then to reintegrate that in a much broader vision, and that means that maybe improving quality may also be possible if we can in parallel improve safety, and so I have proposed some avenues for monitoring patient after surgery, but maybe not only in wards, maybe in the community. Maybe that will need some big cluster randomized trials, as I mentioned, with the guideline implementation trial PANDAS 2. So maybe that in 2-3 years I'll come back to the hospital and just say that we have no new guidelines, but we need to test, will your hospital be randomized to early implementation or late implementation? That's such kind of innovative design that we may consider for improving knowledge, but it's not that easy at all, and even the endpoint selection won't be simple to identify, but maybe also something about de-escalating earlier and then maybe not admitting people to HDU as frequently as we do now, because maybe the kind of wearable technology may help to consider that people are fit for the ward, but in the same time by increasing level of safety and monitoring and not decreasing the level of safety because not admitting them to the high dependency unit. But if it's possible, then it might be possible to promote early recovery more easily than in HDU, because then restricted to the bed mostly, even if going to the chair, but definitely not ambulating as they could in the ward. I dream about automatic way and feedback to clinicians. I just mentioned here postoperative mortality, but we desperately need data, and we desperately need to know what happens after surgery. Most of my colleagues, and partly like me, have difficulties just to know what's the outcome of our patients. So that's difficult when we go back to implementation and when we go back to the leadership aspects, which is one of the key elements when implementing pathways, sometimes more than evidence. Good or bad, that's another discussion, but the fact is that it's mostly dependent on leadership. If people don't have the direct experience of such kind of issue, that's not simple, and I think that monitoring may help to capture that better. I don't know if you have any question or comments, or even the embarrassing one.
Just maybe a question regarding the adoption of continuous monitoring solution from a nurse's standpoint. Because, I mean, today they're running spot checking in the general wards. I mean, transitioning to continuous patient monitoring might be a big shift, you know, and
an enormous one,
nurses are most of the time not technology adverse, but it takes so much time
Yeah.
for them to adopt new tools. I mean,
Definitely, yeah.
I mean, do you see that as a
Yep.
barrier to
Yeah,
get to where you want to be?
I like the comment or the phrase about not. So what was your exact wording? Not a single click more or something like that. Yeah.
One single click more, basically.
If it simplifies job, the nurse work, that I think that will be relatively easy to implement. If the nurse is convinced that she's relieved or he's relieved. One example of that is that this paper sheet accompanying patient being prescribed morphine PCA, and then at the beginning of the night when a patient comes back from the ward with that kind of sheet, so night of the nurse won't be the same, because having to go every hour to collect respiratory rate and even not checking the saturation at all, because trying not to make the patient awake during the first night. So the quality of the monitoring is debatable and is anyway an enormous burden. So if we may identify all the places where it would be possible to simplify people work by, and in the same way, simplify so improved quality and simplify the job, I'm pretty sure that will go relatively quickly, but it will probably need discussions locally to be sure that it matches well local habits, because it might be very different from one hospital to another. In the UK, probably a little bit easier, because my experience is that habits and the way or the pathways or protocols and existence of the news chart and things like that are much more homogeneous than in other countries. In other countries, we just reinvent the wheel in one hospital versus another, even if we've seen Bradford Center with totally different ways to consider pathways. But I think that the UK is much more homogeneous than other countries. But even that, it's very, very different. So some clues that Frédéric Michard proposed was, for instance, avoiding alarms in inpatient's room, but also managing the risk of false alarm will be an important aspect. That may depend maybe on the level of safety that we would like let's say the opposite, the false alarm rate that we would accept. So for instance, I can accept a high rate of false alarm when I'm in the operating room, because I just have to press the yellow button. It's very easy, and it might be different if the nurse has to go or to leave a patient to see another patient alarming. That's a possibility. Wireless monitoring, if we dream about something after discharge with wearable device, that will be probably to alarm patients directly and not to alarm healthcare professionals needing to contact the patient because an alarm happened. So we will have to consider simple alarm and management of false alarm for non-healthcare professionals. But that's probably doable, and that could be based on trends or just intermittent discussions with healthcare professionals, so not necessarily real-time alarms. But so that will need a lot of discussion just to be sure that it improves safety, but also it simplifies management. Yeah. And if it does, we have seen even our older parents and things like that sometimes buying smartphone, and because they can have a call on WhatsApp rather than taking the car. So if it simplifies life, even 70 plus will adopt technology.
I think if you look at where we are now in terms of most health institutions, hospitals in the UK, take spot observations. moving to something like a continuous monitoring, you've got to ask, what is that organisation going to, what's going to drive it in that direction? So in Edinburgh, for example, we know that people make mistakes in calculating an early warning score. They do the maths wrong.
Mm-hmm.
Observations are scheduled for, let's say, 4 hourly or hourly. Often it's very busy on the ward and it doesn't get done on time. So what would implementing something like that, what benefit would it give? So the first step you've got to be able to show is that the problem is that you aren't taking a continuous measurement. And at the moment, I think most hospitals are probably thinking, actually the problem might be that we're not taking our observations at that correct period, or we're making mistakes adding things up. So you've got to get an organisation to the point where it's doing those things correct. It has a baseline. You can say, we're as good as we can get with spot observations. We've still got this element of cardiac arrest that hasn't been fixed by doing that. How do we take that forward? We need to move from spot measurements to continuous measurements. And so until you've got a baseline that you know is reliable with the best you can be with spot measurements, have you got a sufficient driver to invest, let's be honest, money in moving to a continuous measurement? Will it make much difference? And that's probably the kind of thing that most hospitals will first of all say, we're short of money. Is this an investment that will make a significant patient safety benefit? And I think we have to, certainly in Lothian, we're trying to move to electronic calculation of early warning scores. Ryan may or may not be there. It's happening. And in places in London where they've done that, they've shown a significant improvement in identification of a deteriorating patient and an escalation of that deterioration in a timely fashion. Are they then going to say, actually it's worth the investment in moving from that level to something that's continuous measurement? And I'm not sure at the moment we've got enough data to be able to show that this is much better. It might be. The other thing that strikes me when, I forget who it was demoed it to me the other week, or said come along to this, early warning score measurement requires more than what that can acquire. It requires an input in terms of, is the patient on additional oxygen? What's the flow rate? You can't, in that or your competitor solutions, you can't acquire that electronically. It requires a human being to say, yes, you're on oxygen at X litres per minute. So does that give you a continuous calculation of early warning score, or is it still reliant on a human being at periods to say, yes, I've adjusted the oxygen rate that this patient's on? And I'm kind of perhaps jumping the gun with you talking about this in a little while, but I'm not sure at the moment this is the technology game changer that moves us from spot measurements to a continuous one. And then there's the practicalities of it. How do you make this work? Do you give this to everyone when they're admitted to hospital? Do you
Good questions, of course. Yeah.
Do you put it on everyone
Yeah.
post-surgery?
Sorry?
Do you mind if I try to answer this? Because it is directly related to the picture on the side.
Yeah.
So the key element about spot monitoring is not the quality of spot monitoring per se, but is the frequency. Okay.
Where's the evidence to say that's the case?
Because I mean, if it's the picture that Professor Forget showed before, I mean, you can have opioid-induced pain or let's say distress. You can have cardiac arrest. The point is you don't identify the right time what's happening. Okay. So the early warning score is good, but let's say if you have a measurement according to the clinical paper that we have studied, every 8, 10, 12 hours, which means 2 times a day. In between, there's evidence that something can change. And I do agree that per se the early warning score can be a valuable number, but you need to you need to take the spot check monitoring at the right time and the right people. If and you can have your vitals, please correct me if I'm saying something completely wrong, that can go ups and downs during the day, and it could be kind of identification of deterioration at an early stage instead of having, let's say, the patient collapsing out of the blue. So to give you an example, if you just look at the SpO2 continuous monitoring, you can have the SpO2 at 96, 97, then you can have a massive drop with the patient having a massive problem. But if you look at the respiration rate in a continuous way, you can see that there's a reduction, because I mean the latency or the delay due to the SpO2 is much bigger than other vital signs. Or if the patient has a mask, I mean that's a way to avoid the problem. I totally agree on the topic of the, let's say, the value has to be low alarms, low level of alarms, low level of false alarms especially, but the key element is to identify if the patient is going to have a problem at an early stage, because now there's the tendency, and I get it, to push the patient outside the hospital, but what's going to happen if the patient has a problem at home? Who's going to intervene? So from a patient care standpoint, the key element is to identify when something is going south and how to intervene proactively. About your question, considering how you know if the patient is prone to having adverse events, at my knowledge, and again, correct me if I'm wrong, in a ward, you keep the patient with a potential higher risk close to the, let's say, to the desk, and there are scoring methods, for example, the ARISCAT method, or there are tons of solution that, well, tons of scoring system that you can use as a, it's a kind of screening method to say, Aldo is very risky, so let's keep it very close, or let's say Kate is healthier, so there's no this big problem. In terms of adoption, you can create layers.
Yeah, I guess my point is, and I'm deliberately being devil's advocate.
Yeah. That's what we need.
This
will cost money, and an organisation will say, well, so what? What difference does this make?
I agree, but
if you say we're only going to put this on patients that are more at risk of deterioration, then the counter argument could be, well, we'll just do spot observations more frequently. If we know this person's going to deteriorate, or is has a higher probability of deterioration, we'll just set the obs as half hourly rather than 4 hourly.
If I may just slightly disagree, but what I do as a clinician in that kind of situation is sending patient to the HDU. And there is then a continuous monitoring, so that's not new at all. Yeah. But what's the cost of an HDU night?
We have a finite amount of beds in HDU and ICU.
So access is then problematic, and also that may limit access to surgery as well. And
but
in terms of
if we're
costs,
going to talk about introduction of a new technology, how we would use it. We're never likely to have enough resource to be able to just give it to everyone. So
no, but definitely needs to modify pathways for more.
If you're considering also viability in terms of interpretation of the data or data measurement as well, you can have the best early warning score. When data are not captured well, you're a little bit screwed. And there are some literature that say that there are high variability in data, captured, and that can prevent this variability as well. You're going to be consistent. Then there is where you place the patches and all this kind of stuff, but the system is intelligent enough to tell you that the system is not, captured well. So you rely
it's
more.
It's a data quality measurement.
So I think this is an important aspect into it. But then I do agree, we do not want to compare, or we haven't done any comparison between the top of the top in terms of early warning score versus continuous monitoring. So that's probably maybe one aspect to consider in the future. this a really breakthrough technology
Yeah.
in terms of clinical evidence
Yeah.
or not? But I actually believe that also patients will prefer to get this kind of technology than just having a nurse coming up.
Yeah, I mean, I was a year ago. I was unlucky to be in one of our wards. I had an accident at home and I broke fractured 4 vertebrae, and I was in hospital for 10 days. And the nurses came along every 4 hours, day and night, for the first 3 or 4 days, and woke me up in the middle of the night to do obs, and it was horrible.
That's exactly the point.
And if I could have just been left to sleep on my own and any of the acquired data, great for me as a patient. But I think there needs to be some evidence that this is better than what doing spot obs is, if we do it properly at the moment. And so maybe between now and 2 o'clock, if you've done those studies, that's great. Because as a lead for medical technology, clinical engineering, that's the first thing that the finance people are going to say to me is, why should we spend money on this?
I think that if we may just think about the simple question, how many HDU nights should be saved, or what will be equivalent to 1 HDU night in terms of number of patients monitored by that, I'm pretty sure that it might be cost efficient. But I'm not a professional of that.
NHS and everything at the moment is fixated on, does it save money?
Yeah, but I think that it's per se doing the analysis might facilitate implementation rather than the opposite.
We do plan this year to carry out multiple trials that will look at ROI data, look at readmission into ITU, look at invasive beds, look at the cost of that, and hopefully by the end of the year have the data that the NHS needs in order to go forward and purchase that kit, because we 100% get it. You're not going to buy something that you don't know isn't approved. So that's what we are working on this year to get that sorted and to get that data collected. There's other regions in Europe who are happy to go ahead and purchase that without that data, but we all know what the NHS is like and how we have to prove that the money we're spending is worth it. So that is on our agenda, and that's something that is a focus for us for Portrait Mobile this year.
We need food now.
Yeah.
Yeah.
We do.
Thank you.